O'clock. Right, we were talking about the heart and yes, cardiovascular system, cardiac and blood vessel system. So, but at the moment, we are just concentrating on the heart. And this is what we talk about, like just think about that, James Fraser, that was what he said, the second principle. And I want you to think, or what I want you to feel is like if it is something dear and near to you once, it will stick to you. It will not be too far from you. So like the same thing, like your basic science knowledge, whenever you get into clinical practice, these basic science information will become knowledge and useful to you. And as I say, like lectures are pretty big. Of course, I just want to explain you as much as I can, as much as we have time. And there are must know, should know, and good to knows. I will say those in the homework and exams, they are must know and should know. So if you can cover those, then you will be pretty good. You will be able to stand in front of everybody with that information. And that's the cardiovascular system. This is our heart. This is our heart, and the heart will pump out blood into a big major arteries, so big large arteries. These arteries gradually branch, and then gradually become smaller and smaller, and finally become thin, fine capillaries from the arterial end. And they will continue as those capillaries in the venous end. And then finally, these venous end capillaries will merge together to form a small little veins, which are called venules. These small little veins, venules, will coalesce each other to become a small vein, and then finally become very large vein. So vena cava, and come back to the heart. The heart will pump out blood into the lungs, get reoxygenated, and that reoxygenated blood will come back to the heart on the left side, and then we start another cycle again. That's the basic of cardiovascular system. And if we go through a little bit more detail, like this is our heart, and we all know that a human heart has got 4 chambers. On the right atrium and right ventricle. On the left atrium and left ventricle. And one thing we should remember is when a heart contracts, either both atrium, right atrium and left atrium contract at the same time, and the right ventricle, and when they relax, right ventricle and left ventricle will contract at the same time. So atrial contraction followed by ventricular contraction. Atrial contraction followed by ventricular contraction. Yes, all the blood from the superior vena cava, like from head and neck portion, we drain into the right atrium. The rest of the body, the blood will be drained finally into the inferior vena cava. We also drain into the right atrium. From the right atrium, it will go through a small aperture, which is protected with the door leaflets, which are called tricuspid valve. From the right atrium through the tricuspid valve opening into the right ventricle. From the right ventricle through the pulmonary valve, pulmonary means lungs, into the lungs, and where the blood will get reoxygenated, and then this reoxygenated blood from the lungs comes to the left atrium. So all the blood from the lungs will get into the left atrium. From the left atrium through the mitral valve, through the mitral opening, we get into the left ventricle. From the left ventricle through the aortic valve, and it will go into the aorta, and that will go into the whole circulation again. So that is that is our heart. So
Okay.
four chambers of the heart,
Bye-bye.
four chambers of the heart. On the right side, right atrium, right ventricle. On the left side, left atrium, left ventricle. The job of the atria is to receive the blood coming back. So right atrium receive the blood from deoxygenated blood come back from the all part of the body, and left atrium receive the blood from the lungs, which is oxygenated blood. Of course, you know, if we look in the book, it is a little bit more complex, but might be more meaningful. Like blood from the right atrium will go through the tricuspid valve into the right ventricle. So right atrium will be filled with the blood from the superior vena cava, inferior vena cava, and then right atrium will collect all these blood through the tricuspid valve. It will drain into the right ventricle, and this right ventricle blood will be pumped up from the right ventricle through the pulmonary valve into the lungs. So the big vessel, which is immediately after the right ventricle, is all called pulmonary trunk. Pulmonary trunk will divide into right pulmonary artery and left pulmonary artery. We go to the lung, and this deoxygenated blood will get reoxygenated, and then that will come back into the left atrium. So this is now left atrium is receiving oxygenated blood from the lung through the pulmonary vein. And we say that anything leaving the heart is an artery, anything coming back into the heart is a vein. It is regardless of the content of the blood. Pulmonary arteries, they are carrying deoxygenated blood, but just because they are leaving the heart, they are named pulmonary artery. And the pulmonary veins, which is coming back from the lungs to the heart, they are carrying oxygenated blood, but because they are going back into the heart, and therefore they are called pulmonary vein. And now the oxygenated blood is accepted in the left atrium. From the left atrium through the mitral valve openly, we get into the left ventricle, and left ventricle will contract, and the blood will be pumped out through the aortic valve into the aorta, big main artery, which is coming out from the heart, and that way the blood will be distributed all over the body. And don't forget, when the heart contracts, either both atria will contract at the same time, or both ventricles will contract at the same time. So atrial contraction followed by ventricular contraction. Atrial contraction followed by ventricular contraction. The right atrium and left atrium, they will contract at the same time. Right ventricle and left ventricle, they will contract at the same time. And as we say, this is the surface anatomy of the heart. The heart is not a very big structure. It might be just as big as your fist. So if you put your fist across your chest somewhere on the lower part of your sternum, that is where your heart is. Of course, this is the third costal cartilage. This is the sixth costal cartilage. On the left, this is second intercostal space, and this apex of the heart is in the fifth intercostal space. Fifth intercostal space is the space between the fifth rib and the sixth rib, and in the mid-clavicular line. So if you draw a perpendicular line from the middle of the clavicle, it is there. So that is the apex of the heart. That is our anatomical location. That is surface anatomy. So it is the heart lies just behind the sternum. It is behind the sternum, which is and the lungs, right lungs on the right side, left lungs on the left side. The heart sits in between two lungs, behind the sternum, in front of the vertebral body. And that space, that particular space between two lungs, sternum at the front, the vertebral bodies at the back, that space is called mediastinum. So mediastinum is filled, is a space which is filled with the heart and the major blood vessels, which is immediately coming out from the heart. And at the base, we have a diaphragm. Diaphragm is a musculotendinous structure, which is a partition between the thoracic cavity and abdominal cavity. So now, once we got this concept, and if we look at that, that is the cadaveric structure. So it is not a big difference at all. So this anterior thoracic wall and the sternum has been removed. You can see the ribs, which are being cut away to open the anterior thorax. And you can see the heart, which is like a little baby's boot shape, and which might be the size of your own fist. And it doesn't weigh much at all. It might be about 300 grams, might be about the size, which is sitting like obliquely in the lower part of the sternum. And that's the apex portion. This is the anterior wall, and this is the right border of the heart. And these are the major blood vessels which is coming out from the heart, aorta, and the superior vena cava, which is going into the right atrium. And if you look at this picture, the apex of the heart is here. That is the floor of the heart, and the base will be at the posterior aspect of the heart. And you can see the right atrium here. And you can see the right ventricle, which is just making the anterior surface of the heart. And you can see the right atrium, which is making the right border of the heart. And this is the left atrium, which contributes the apex of the heart. So now if we have this information, when we see this plain radiograph, so you are going to see these chest X-ray, chest X-ray, chest X-ray every day. I mean, if you walk in the urgent care or emergency or on the ward, you are going to see this chest X-ray every day. And now you can start interpreting a chest X-ray. You can see the right lens, which is here, and you can see the left lens, which is here, the black darkish shadow lens here, and you can see the shadow of the heart. You can see the shadow of the heart, and now you can say this anterior surface of the heart is made of right ventricle. This right border of the heart is made of right atrium, and the apex of the heart is made of the left ventricle, and left atrium might be somewhere around here, but it makes the most posterior part of the heart, so which is at the back of the heart. So now, because we have this anatomy knowledge, and we got this cadaveric information, now we can change our information into knowledge and wisdom. So right border of the heart is here, the floor of the heart, which is sitting on the diaphragm, and the apex of the heart, which is somewhere around here. Okay, so yes, this is the right atrium, this is the anterior surface of the heart, which is mostly made of the right ventricle, and this is the left ventricle, and the apex, which is made of the left atrium. And you can appreciate now this small little left atrium, which is not much in the front, but that makes the most posterior portion of the heart. And you can see the superior vena cava, superior mean up, vena cava mean big vessel, coming into the right atrium, inferior vena cava, everything coming down from the lower part of the body, we drain into the inferior vena cava, and they will get into the right atrium. Okay, so now this is not a very difficult chest X-ray for you. You can see the lens, you can see the heart, you can see which portion of the heart is made is which part of the heart. So that is right atrium, right border of the heart, right ventricle, most of the anterior surface of the heart. Left atrium is just a small portion, and left ventricle contribute the most inferior surface and the apex of the heart. And now if we go to next step, then this is what we talk about. In 1800s, like that's the way physician listen the patient's heart. Then gradually from here, this is the drawing from Paris. It's 18 90s. Like that's the way a physician has to listen to somebody's heart. And from that, they try to make a roll of the sheet of paper like a tube and listen, and now stethoscope begin. And these days, these are the stethoscope we use every day. So how do we, if we want to listen to somebody's heart, we know where to listen so that we can interpret the sound we are going to hear. So like our surface anatomy, which comes into play on this diagram. And we said third intercostal space, a third costal cartilage. This is sixth costal cartilage. This is second intercostal space, and this is apex of the heart, fifth intercostal space in the midclavicular line. That is our surface anatomy. And now we are taking that information into our clinical practice. And that is what we are going to listen. Of course, you won't be trying to listen on a bone. So you will just slightly change your stethoscope position. So this is second intercostal space, just on the right side of the sternum. And that is where you listen your heart sound. And the same thing, like tricuspid heart sound, tricuspid valve heart sound, you will be listening in the, we said, sixth chondral cartilage. Of course, we won't be listening a heart sound on a bone. So we'll just slightly shift our stethoscope slightly upwards. So we will be listening in the fifth intercostal space. That is the space between the fifth and the sixth rib, just on the right side of the sternum. And the same thing, like, the surface marking, second intercostal space. Of course, it is a good place to sit. That is this place for the pulmonary valve, and apex of the heart is a good place to listen the mitral valve heart sound. That doesn't mean the heart valves are exactly where they are, because if you look at this center here, these are where the valves exist, but we are listening the sound in a slightly more audible place, let's say. So when the mitral valve is here and we listen the mitral valve heart sound here, because the blood we have to come from the left atrium through the mitral valve into the left ventricle. So it might be better if we listen from the opposite side where the fluid, which is blood, is flowing from. So that's, aortic valve, mitral valve, pulmonary valve, and aortic valve, tricuspid valve, pulmonary valve, and mitral valve. The way I try to remember is ATPM, at PM in the afternoon. Aortic, pulmonary on the right, just on the right side of the sternum, second intercostal space, fifth intercostal space, and PM, pulmonary and mitral valve, second intercostal space, and the fifth intercostal space in the midclavicular line. So that is where we listen the heart sound, but the exactly heart valves are located is slightly different from where we listen, right? So that is we have talked about, and this is a little bit more elaborated diagram, which is from the clinical textbooks. So, but I will be happy if you remember just this diagram. If you have time, just have a look. This is a good to know diagram. And this is the EKG or ECG. It is a standard 12 leads ECG. Standard 12 lead ECG, like we get augmented vector right, we have augmented vector left, and we have augmented vector inferior. That makes 3. And lead 1, lead 2, and lead 3, that is another 3. And that these are the anterior leads, like leads V1 to 6. So these anterior leads 1 to 6 will be looking at your heart directly from the front across your chest from right to left. And this AVF will be looking to your heart from the bottom of your body. This way, AVR will be looking at your heart from the right side, and AVL will be looking at your heart from the left side. What does it mean? So if there is any problem with the 2, 3, and AVF, that means these 3 leads, they are looking at the heart on the inferior surface of the heart. And that is if there is any problem with 2, 3 AVF, that is something is going wrong with the inferior portion of the heart. That's the way, if there is any problem with V1 and V2, that will be right anterior portion of the heart is in trouble, and V5 and V6 is if something goes wrong, then that will be left portion of the heart anteriorly, which might represent the left ventricle, and this is representing the right ventricle. So that's the way we interpret our anatomy knowledge, which heart chamber is where, and making what portion of the heart, and looking with the ECG, and we are trying to interpret the ECG. Right, let's move on. So what have we learned so far? We have talked about anatomical location and the mediastinum. We talk about chambers of the heart, and we talk about blood flow through the heart, right atrium, through the tricuspid valve, into the right ventricle, through the pulmonary valve, into the lungs. The lung oxygenated blood will come back into the heart, into the left atrium, through the mitral valve, into the left ventricle, and then through the aortic valve will be pumped out into the aorta and distributed to the whole body. And we talk about heart sound, where the valves are, and where do we have to listen. So where do we listen our heart sounds? It is just the anatomical location of the heart, if we remember that. Okay, so this is, what is this? This is the, of course, cardiac muscle tissue. Can you really say that? Well, I cannot, but I can say it is a striated muscle, because I can see these striations. I can see these striations, and I can see the Z disc here, one Z disc, which means that is the sarcomere. So I can see the Z disc. So that is a striated muscle, and we know that cardiac muscle is a striated muscle. Skeletal muscle, it's also striated muscle, but what's the difference? The difference is skeletal muscles are much longer, linear, and larger. They do not branch, they do not join. The cardiac muscles are slightly smaller, and they do branch and they do join. And now we can appreciate the intercalated disc, which is the horizontally placed to the longitudinal axis of the cardiac muscle. So what are the intercalated discs? Of course, that is a junction between one cardiac muscle cell and another cardiac muscle cell. So one cardiac muscle cell, we start from here, another cardiac muscle cell, we start from here. So this is a junction between the 2 cardiac muscle cells, and you can also see 1 and 2 nucleus. So cardiac muscles is not a surprise, striated muscle. They do branch. And junction between the cardiac muscles are called intercalated.
But so I say, I don't move out. You said your dad said something. Did something.
Because no, he really did not want me to have the room at all. He didn't want me to have
The garage?
the garage.
Why? Was he
Yeah.
going somewhere?
Wasn't doing shit.
All right. So intercalated disc has a 2 region, transverse region and longitudinal region. This is the knowledge which is pretty far deep into the, really deep into the cardiac muscle. So yes, try to understand, try to appreciate, but don't worry too much about that. Fascia adherence and gap junctions. Okay, so this is the one cardiac muscle cell, another cardiac muscle cell, stop here, and here will be another cardiac muscle cell here. So this is the cardiac muscles. It is very much similar to the very similar to the what you call the someone is having arrhythmia. So there was a question like for what's happening when someone is having arrhythmia. So arrhythmia, we get into that section. Arrhythmia means the heart is, the different portion of the heart is beating in a different way. So we get to the near end of the lecture about the arrhythmias. And look at that, it is very similar to the skeletal muscle, the calcium, the electrical signal impulse will come and stimulate the heart. There will be calcium, that calcium will be going through the sarcoplasmic reticulum and T-tubules, go every part of the cardiac muscle cells, sarcomere, and then the cardiac muscle will contract. And as we know, like in skeletal muscles, we have I-band, A-band, and Z-disc, the same in the cardiac muscle. So the cardiac muscle is very much similar to the striated muscle, just a few difference, which is not difficult for you guys to remember now. So we, A-band, I-band, like our favorites, you know, like when we talk about this skeletal muscle, they all come into play when in the cardiac muscle. So let's move on. Cardiac muscle cells, intercalated discs, these are the junction, and this is the what we were talking about, the gap junction and the fascia adherens. These are located in the intercalated discs. Don't get too much involved with this. It is a little bit more like a good to know, not must know or should know. So this is our skeleton, and skeleton is filled with all the muscles. So if we strip all these muscles from a body, we will get the skeleton. So if we have skeleton for the whole body, the heart itself also have a skeleton as well, but of course it is not made of bone. The cardiac skeleton is made of just connective tissue. So these connective tissues are enclosing the muscles. So cardiac muscles are enclosed with the connective tissue, and this connective tissue acts as skeleton. So it will give us a structure, making sure it is not truly too much expanded, giving attachment for the same thing like the bones give attachment for the muscles. So the cardiac skeleton will give attachment for the heart valves and so on. So the cardiac skeleton, I would say, you know, it is not really a skeleton. It is just a connective tissue, which is made of connective tissue, and it's just spiral around the muscle, and it's also around the heart valves. So these are the job of the cardiac skeleton, which is attachment for the heart valves, attachment for the cardiac muscles. And it prevents the over dilatation of the heart, so that it is just squeezing the heart, keeping the heart in the same shape. And this connective tissue will block the passage of the electrical impulse, so the unwanted electrical impulse will not be able to cross as wherever they like. So yes, I mean, that's the shape of the cardiac skeleton. Actually, these are made of cardiac muscles, which are going in spiral. Look at that, you know, a spiral around the heart atrial chamber. It spiral around the ventricular chambers. And these muscles will be enclosed within the connective tissue. That connective tissue is called cardiac skeleton. And look at that, you know, the way they are designed is, the muscles are designed, it's like a spiral shape. It's like a circular shape in the atria, so that when the atria contract, squeeze, the direction of the flow will be going downwards directly into the ventricles. and look at the shape, arrangement of the muscles and the connective tissue of the ventricles. It is just like a spiral ring, which means this, if this heart, right side of the heart contract, it will just lead up here. It's going upwards, and left ventricles contract here, it will just squeeze it out and force it and pump up into the aorta. That's the way it is cleverly arranged. So now this information became TDS, the heart and the mediastinum and the blood vessel, and this is our heart. Of course, this diagram is slightly more complex, and we know that right border of the heart is made of right atrium, anterior surface of the heart is made of right ventricle, and lateral and the apex of the heart is made of the left ventricle. And what we want to understand from this diagram is the blood vessels for the heart. So these blood vessels of the heart, they are running in a groove, which is what we call a sulcus. Sulcus is a groove, and it is a coronary sulcus. Corona, crown, coronavirus. It's like a little spiky crown virus. And this coronavirus is this corona is a crown which is going to sit on our head like that, like a head, it's just going to sit on our head. So this coronary sinus is going to go on the upper head portion of the heart. So this coronary sinus will split the heart into upper atria and lower ventricles. So this is the right coronary groove, and this goes left coronary groove, and in the back we have coronary groove as well. So these are the coronary sulcus groove, in which coronary arteries, the arteries for the heart muscles, runs in. So these coronary arteries start from the aorta and start as a right coronary artery and the left coronary artery. Right coronary artery run in the right coronary sinus in between the right atria and right ventricle. And this right coronary artery will get a little branch to the right ventricle anterior wall, which is what we call the right, and it will just keep going, and then it will give a branch at the margin of the inferior border of the heart, which is called the marginal artery, and it will loop back, and we'll see the posterior surface of the heart in the later diagram. So that is the right coronary artery, which is originating from the aorta, running in the right coronary sulcus, which is a groove in between the right atrium and the right ventricle. And this artery is going to serve the right atrium and right ventricle. Of course, it will serve everywhere nearby structures. And the right marginal artery will be at the margin inferior border of the heart, and the coronary artery will continue and spiral back. What about the left coronary artery, which is originating from the aorta? This left coronary artery runs in the left coronary groove, and then suddenly it just divides into two main branches. So one branch, it will keep going back and loop around, circumflex, loop around to the posterior surface of the heart, which we will see in a later diagram when we see the posterior surface of the heart. And another artery which will be coming directly in a groove, which is separating the right ventricle and the left ventricle. So in between two ventricles, that is what we call interventricular groove. And this artery is named interventricular artery. Of course, it is in the anterior aspect of the heart, and therefore we will give a name, anterior interventricular artery. In between two ventricles, it will just go straight downward. So it is going to give blood supply to the right ventricle anterior surface and of course left ventricle as well. So that is the anterior view of the heart and its coronary artery. So let's say if we flip it and if we look at the posterior surface of the heart, that is what we are going to see. you can see the right coronary artery, which is continuing in the coronary sinus as coronary sulcus. And if coronary sulcus, and we just carry on like that, continue as a posterior interventricular artery. Of course, this is the left ventricle, this is the right ventricle, in between two ventricle, interventricular artery, but it is in the posterior surface of the heart, and we will give it a name, posterior interventricular artery. Look at the circumflex artery, which is a branch of the left coronary artery, which is running in the coronary sulcus, and it will just give the blood supply to the some of the posterior surface of the left ventricle. And the veins for the heart is easy to remember, but let me carry on with the arterial supply. So this is the right coronary artery, left coronary artery, which divide into left circumflex, and anterior interventricular artery, right coronary artery, which will give a marginal branch and continue as a posterior interventricular artery, and that will be the posterior descending artery. So that is the arterial supply for the heart structure itself. And if you look at the veins, you know, the veins follow the artery. That's simple as that. So anterior interventricular artery will be followed by the great cardiac vein. Hey, the name is great cardiac vein. If we have great cardiac vein, we will have the, look at that great cardiac vein continuing as like that. And we will, what is that? If we, in the posterior surface, we will have the posterior vein. We have the middle cardiac vein, great cardiac vein, middle cardiac vein, and finally all the veins will drain into the big confluence of vein, which is called coronary sinus. And this coronary sinus again will go into the right atrium. So all the deoxygenated blood, the oxygen has been used by the cardiac muscles, will be taken back, the blood will be taken back into the right atrium. So this is a good way to remember. So what I want you to do is, I want you to draw this diagram or something similar, whatever you feel like it, like a simple diagram, like a free body diagram, you know, just an easy way to remember the blood flow. And the importance of these arterial coronary artery is if a blood vessel block, which part of the portion is going to get damaged, like myocardial infarction. Myocardial infarction means blockage of the coronary arteries. Let's say if the blockage of the right coronary artery, then the problem will be in the right atrium and right ventricle. If the blockage of the coronary artery is in the anterior interventricular artery, then the most portion is going to damage is the left ventricle. The reason is right ventricle, the blood supply is not as much as the left ventricle, plus the right ventricle, we have some sort of blood supply, some source of blood supply from the right coronary artery. But if there is any blockage here, this ventricle is going to damage much quicker and easier. So that is the knowledge which we need to take when it comes to the heart attack or myocardial infarction, and then which vessel get blocked will lead to which portion of the heart is going to suffer, and that will lead to the ECG, which portion of the ECG we need to look at. So let's say if there is a inferior border of the heart is going to damage, we know that 2,3 AVF leads is going to change. And if we see 2,3 AVF leads changes in the inferior border, changes, that means inferior border of the heart is going to get damaged. And we know that the blockage might be right coronary artery or might be distal portion of the anterior interventricular artery. That is the information and knowledge we take basic science knowledge into the clinical practice. Right, this is a little bit clear picture. We can see the right coronary artery, right and anterior interventricular artery. And here there is one more additional branch. Forget about that. That is a little miniature. If we stick with those previous diagram, that's one, I think you will be fine. So arteries for the heart, we have talked about that already. And the veins, great cardiac vein, middle cardiac vein, and small cardiac vein, we see that they finally go into the coronary sinus. And let's open the heart and look inside the heart. If we look inside the heart, we know that we have two atria, right atrium and left atrium, and we have two ventricles, right ventricles and left ventricles. And all the bloods from the head and neck, so upper portion of the body, will be draining into the superior vena cava and finally come into the right atrium. All the blood from the rest of the body, and especially from the lower part of the body, will be draining into the inferior vena cava, and that will also again drain into the right atrium. So right atrium will receive all the deoxygenated blood, used blood from every part of the body. And look at that, the small surface of the right atrium is pretty smooth, and you can see the opening of the inferior vena cava and opening of the superior vena cava. And this area is nice and smooth. And you can see the crescent shape here. You can see the little crescent shape here. That is, so these vena cava openings are behind the crescent shape. And that's the coronary sinus, which is the vein for the heart, will come back into the right atrium just in front of this crescent shaped ridge. Okay, so, and you can see some portion of the ventricle is a little bit ragged. These are the ragged because of the muscles. These muscles are called pectinic muscles. So posterior surface of the right atrium is smooth, and anterior surface, which we have removed to show the inside of the heart, anterior surface of the heart, we have pectinic muscles. The same thing, most of the left atrium surface is smooth, but just very small portion of the left atrium, we have pectinic muscles. And we know that the blood from the right atrium will go through the tricuspid valve, tricuspid opening into the right ventricle. Hey, look at the surface, interior surface of the ventricles. Right ventricle, left ventricle. The surface, interior surface of the ventricles are a little bit ragged with the muscles and a little bit some tendons. So this is the tricuspid valve. Tricuspid, as the name tells, that tri means three, cuspid means valve-like, leaflets, three leaflet valves. So the tricuspid valve has three leaflets, and leaflets are attached to the wall of the ventricles via the tendon, which we call chordae tendineae. So these are the tendon which is connecting the valve leaflets to the muscle. They might be chordae tendineae, might be going to the papillary muscles of the ventricles, or they might be going to attach to the trabeculae carneae. So trabeculae carneae, it's a big name, but don't take it too serious, okay? So trabeculae means trabecular-like carneae. So like trabeculae, this is what we have seen in the bone structure, trabecular meshwork. So trabeculae carneae is just like a trabecular shaped structures, which is pretty similar and job function as well, similar to the papillary muscles of the heart. They are arising from the walls of the ventricle, which give attachment for the chordae tendineae attached to the edge of the tricuspid and mitral valve. So the pattern is pretty similar in right ventricle and left ventricle. What is their job? Their job, so when look at the opening direction of the valves of the tricuspid valve, they will open into the ventricle. Of course, the blood is flowing from the atrium into the ventricle, atrium into the ventricle. So the valve will open into the ventricle. And when the ventricles contract, these valves will get pushed up, and then that will block the opening so that the blood can go only into the pulmonary and aortic valve, not back into the atrium. So to make sure the valves are not being pushed too far back into the atrium, these chordae tendineae, they will open, they will pull the valve leaflets so that this valve will not bulge or push back too far into the atrium. So that is the way, you know, these papillary muscles and the trabeculae carneae will work. So they will give attachment to the chordae tendineae, which will chordae tendineae will attach to the margins of the tricuspid and mitral valve, so that when the ventricle contract, the valve will not be pushed back too far into the atria. So that is, if these muscles are not working properly, when the ventricles contract, the valve, edge of the valve will prolapse into the atria. That is heart valve prolapse, which we do not want. If there is prolapse, when the ventricle contract, the blood will go not only to the pulmonary or aortic, will also go back into the atrium. That is something we do not want. All right, so yes, let's split the heart into 4 chambers: right atrium, left atrium, right ventricle, and left ventricle. And if you think the atria internal anatomy and ventricles internal anatomy, right atrium and left atrium, they are pretty similar, or might be pretty much the same. And right ventricle and left ventricle, they are pretty much the same. It is pretty much identical. But look at the walls of the left atrium. Look at that, the walls of the left atrium is very thick, and the wall of the right atrium is not as thick, but it is still thicker than the walls of the atrium. Why is that? Because the left atrium has to pump out blood up against the resistance into the aorta to distribute to the every part of the body. So therefore it needs a lot of force, and therefore it needs a lot of muscle. It needs a lot of muscle, meaning it needs a lot of blood supply. That is why usually whenever someone has problem with the heart ischemia, the lack of blood flow to the heart, it is mainly in the left ventricle. Right ventricles, it has to pump the blood through to the lungs, and therefore its muscles are stronger than the atria, but not as big as the left ventricle. And of course, the atria, right atrium and left atrium, their job is to accept the blood, and its easy job along with the gravity, it will squeeze the blood from the right atrium into the right ventricle, left atria into the left ventricle. So they have a relatively easier job, and therefore their walls are thin and their muscles are not as strong. So I hope it is not too confusing. So let's look at that. This is the chest cut open, and then look inside the heart, the thickness of the left ventricle, thickness of the right ventricle. There is a big difference. Does the heart repair itself after a heart attack, or is permanently damaged? It is permanently damaged, because heart attack means lack of blood flow to the heart muscle. There is no more oxygen to the heart muscle, and there is no more energy production, and there is a death of the cardiac muscle. That is what we call myocardial infarction. Infarction means death of the heart muscle. So as we say, a muscle will never regenerate. if we have a bone fracture, if we take a piece of bone, if we remove a piece of bone, the bone will regenerate and the bone will regenerate with bone. So as we understand from our previous lecture, when there is break in bone, there will be bleeding. The bleeding will become blood clot. The blood clot will be infiltrated by multiple cells, inflammatory cells, and then the osteoblast will come in, osteoclast will come in, and then that way the bone will regenerate bone, and the bone healing finally come back with the bone. And for the muscle, like our skeletal muscle or the cardiac muscle or the smooth muscle, these muscles, they do not regenerate. So we remember Arnold, like, it's big body, big muscle. Let's say if these muscle got damaged, this muscle will never regenerate. So it will, this dead removed portion of the muscle, dead portion of the muscle will be replaced with the scar tissue. That's why, once someone has a heart attack, that it depends on how big the damage is. Is it a small piece of myocardial infarct or larger piece of myocardial infarct? And that will lead the prognosis. Right. So this is the heart looking inside the chamber of the heart. That is the thickness. Look at the thickness of the left ventricle. Of course, it has to pump blood against all the resistance to every part of the body, from the top of your head to down to the tip of your toes. The amount of pressure it needs is more than 120 millimeter mercury. Just pump it out. So it needs a lot of big muscle. Big muscle means it needs a big blood supply for big oxygen demand. And if you think about that, your heart is never stopping structure. Even when you sleep, they stay beating. So it is such a lot of oxygen demand, a lot of oxygen requirements in the cardiac muscle. So yes, look after your heart. So these are the blood supply of the heart. It's becoming too boring for you guys. You are expert already. And don't forget to look at this diagram again, especially looking at the trace, the arteries and veins, and draw a diagram. Right, let's move into, this is blood vessel. So we talk about heart, and if we talk about blood vessel, combination of heart and the blood vessel will make a cardiovascular system. When we talk about the blood vessel, we will have three layers in a blood vessel. So the three layers are tunica, intima, media, adventitia. So intima means intimate, very close to the blood, which is the innermost layer of the heart, tunica, intima. Tunica media means middle layer, which is muscular layer. Tunica media, middle layer, muscular layer. And adventitia, it is the outermost layer of the blood. So I think, if you think about any part or most part of the body, how many layers do you have? If they ask, I want you to answer 3. Every part of the body, like abdominal muscles. How many abdominal muscles do we have? I want you to say 3. Chest wall in between the ribs, the space, intercostal space, these spaces are filled with the muscles. How many muscles do we have? I want you to say 3. Abdominal muscles, how many big abdominal muscles do we have? I want you to say 3. Artery, how many layers do you have? I want you to say 3. In tunica, intima, media, adventitia. And so let's say, what about the heart? How many layers do we have in our heart? I want you to say 3. So 3, 3, 3. I don't know why we are structured that way. Might be, easy for the students to remember. So easy for everyone to remember. Hey, you don't need to think too much. How many layers do we have? Like intercostal muscles. How many intercostal muscles do we have? Intercostal muscles are the muscles in between 2 ribs. So filling the intercostal space, three layers. How many abdominal layers, Marcus layer do we have? 3. How many meninges, which is the covering of the brain, do we have? 3. As dura mater, arachnoid mater, pia mater. So the brain is covered with the 3 layers of meninges. The brain is covered with meninges, which has 3 layers. So every part of our body is like 3, and blood vessel 3 layer. And of course, the heart, how many layers do we have in our heart? We will have 3 layers. So what are the 3 layers of the heart? Endocardium, myocardium, and epicardium. Endocardium, innermost layer, like the intima, tunica intima in the blood vessel, which is direct in contact with the blood, tunica intima, media, and adventitia. Inside out, let's say if we go to the heart muscle, from inside out, endocardium, myocardium, and epicardium. Endocardium is the innermost layer, which is in contact with the blood. Hey, endocardium, innermost layer. The job is to make the life of the blood easier. So because it is in contact with the blood, its job is to make the blood going smooth and support the blood. So it doesn't need much. So it is just a thin layer of cells, which is the simple squamous epithelium. So endothelium is made of endothelial cells, which is nothing more than the simple squamous endoepithelium. Yeah, myocardium, of course, you have seen the myocardium. Myocardium is made of the cardiac muscle, which is very thick, and you have seen the cardiac muscle cells, intercalated disc, A, I, Z, everything you have seen. And epicardium is the epi mean outer covering, and epicardium is the outermost portion of the heart. This epicardium is slightly twisted, and we have to pull ourselves together. Epicardium of the heart is made of the visceral portion of the serous pericardium. So we talk about pericardium. I have talked about pericardium, and I have talked about the serous portion of the visceral layer of the serous of the pericardium. So let's talk about the pericardium. So pericardium around the heart. So the way you should think about is the pericardium itself is your boot. So your big boot, like Nike or Adidas or New Balance or whatever you use, the big boot is a pericardium. It is a very thick, dense, protective structure, which is keeping your heart in that particular position inside the mediastinum. Because if you do not have a pericardium, then your heart, once it beats, it will just jumping around inside your thorax. We can't let it happen. We have to keep the beating heart in one particular position. And that is the big boot we need, and big pericardium. That big boot is what we know as the fibrous pericardium. Yeah, of course, you know, when we wear a shoe, you are not wearing the shoe into the boot straight away. You will put the socks on your foot. So on your feet, the socks you are putting on is the serous pericardium. So the big boot itself is the fibrous pericardium, which is keeping you damaged from the other structure. And the inside the boot, we will use the socks, our socks, like, which is the serous pericardium. And this is a special socks which has got 2 layers, visceral pericardium and parietal pericardium. Visceral pericardium will be in contact with the heart, and the parietal parietal serous pericardium will line the fibrous portion. so that the parietal will be outer layer and visceral serous pericardium is the what we call epicardium. So this is what it is. So epicardium is the visceral portion of the serous pericardium. Might be a little bit confusing. Let's go to this diagram. So let's finish this diagram before we take a break. So we are looking at the outer portion of the heart. We can see the myocardium, which is made of the muscle. Inside the myocardium, this is the chamber of the heart, which is filled with the blood. And the inner portion of the myocardium is lined by the endocardium. As we say, endocardium is nothing more than the flat squamous cell. And the outer portion of the myocardium is covered with the epicardium. So look at that, this dense fibrous structure, which is the outermost, that is fibrous pericardium. And that's fibrous pericardium. Inside the fibrous pericardium, we have serous pericardium, which is a folded structure. The serous pericardium will line the inner surface of the fibrous pericardium, and we also line the outer surface of the myocardium. So it is a folded structure. The whole structure is called serous pericardium, and serous pericardium, which is on the myocardium side, is called epicardium, and it also lines the inner portion of the fibrous pericardium. So parietal layer of the serous pericardium and visceral layer of the serous pericardium. Visceral layer of the serous pericardium is called epicardium. So the serous pericardium, which make a space, potential space, and that space is filled with the pericardial fluid. So just a very, very thin layer of fluid, like the fluid in our knee joint. And this fluid makes the two layers of serous pericardium, make it smooth, so that when the heart is contracting, there is making fluid and that there is no friction. So otherwise the heart will be frictioning against the heart fibrous pericardium. We do not want that. Therefore, we use the little socks, which has got two layers, and in between the parietal layer and the visceral layer, this space is called pericardial cavity. That pericardial cavity is filled with the pericardial fluid, which is just a little potential space. There is no space at all. It is just for the thin layer of fluid, which is going smooth, so that when the heart is beating, it is beating against a smooth surface and no friction. That is what we want. And if there is too much fluid in the pericardial cavity, that is what we have, pericardial effusion. So this is the cross section or axial section or transverse section of the thorax, which is heart. We are looking from the bottom. This is the right side, this is the left side, and this is the heart. This is the mediastinum. We have known this already because this is the sternum on the anterior aspect. We have the vertebra at the back. We have right legs on the right and we have left leg on the right. And there is an extra fluid inside the pericardium. This condition is called pericardial fluid. Too much pericardial fluid. Too much fluid is called effusion, pericardial effusion, which is the accumulation of fluid in the pericardium, which is in between the visceral layer of the serous pericardium and the parietal layer of the serous pericardium, which is inside the fibrous pericardium. So the job of the fibrous pericardium is to keep and protect the heart in its position. And the job of the serous pericardium, which has got two layers, is to secrete small amount of fluid, which is what we call pericardial fluid. That creates the little potential space for just for the easy movement of the heart inside. But if there is too many fluid inside the pericardium, this is what we have, pericardial effusion. Hey, finally, it comes to all this. So it is 11 o'clock and we are now 11 So shall we take 10 minutes break? So, right, so this is our circulatory cardiovascular system, the heart and the blood vessels. And this is something we have talked about. You know, every part of the body, like from head and neck region, from upper limb, so your arms, we come back, we finally drain into the superior vena cava. Superior mean above, vena cava mean like a cave, big blood vessels, venous blood vessels. We come into the superior vena cava, and the abdomen and lower limb, they will all drain into the inferior vena cava. Finally, there we have to, so you can see the blue blood coming back from superior vena cava, inferior vena cava. They will all have to come into the right atrium. Now the blood is located in the right atrium. And from this right atrium, let's have a look. So from the right atrium, the blood is filled already. With the gravity, the blood and the tricuspid valve will open, and with the gravity, the blood will be gradually flowing into the right ventricle. And of course, you know, at the end, the ventricle, right atrium, we have to squeeze the finite touch of blood to be pushed into the ventricle. And look at the opening direction of the tricuspid valve. It is open into the right ventricle. And now the ventricles are gradually filled up. And now ventricles are really full up already. And now ventricle will start squeezing and contracting. And at the very beginning, it will push up the tricuspid valve and close the tricuspid valve so that no more blood can come into the ventricle. And these tricuspid valves are secure enough so that the right ventricle contraction will not lead the blood flow back into the atrium. So this tiny tricuspid valve needs to be competent in what it is doing. It needs to be open fully when the atrial bloods are coming into the ventricle. And at the same time, once the ventricles start contracting, it needs to be closed enough, tight, watertight enough so that the blood cannot leak back into the atrium. And there is only one way flow. So it will lead, the blood will lead and push towards the pulmonary tract. And with time, the pulmonary valves will open upwards, and then it will flow into the pulmonary tract and into the right and left pulmonary artery. Right. So from right and left pulmonary artery, the blood will be taken to the lungs where it gets reoxygenated. Then reoxygenated, and the reoxygenated blood from the lungs will come back into the left atrium through the pulmonary vein. Yeah, so be careful, it is pulmonary vein which is carrying oxygenated blood. We said vein because it is coming back into the heart, because it is not leaving the heart. So the blood is now gradually coming back into the left atrium, and now left atrium is fully filled already. And filled left atrium will pour blood into the left ventricle, and the opening is called mitral opening, and the valves are called mitral valve. Like the tricuspid valve, mitral valve will open into the ventricle, and now ventricles are filled with the arterial oxygenated blood already, and now ventricle is going to contract. And because of the contraction, the first thing is to close the mitral valve so that there is no more backflow into the atrium. And once the mitral valve is fully closed, and the aortic valve will start open here, aortic valve will be here, gradually open, and then push the blood into the systemic circulation. Now the blood is in the systemic circulation. Of course, you know, these two diagrams, like the veins, arteries are filled, atria contract, going into the ventricle. So these are happening at the same time. So both atria, right atria and left ventricle, are receiving blood and squeezing the blood into the both ventricles. Both ventricles, right and left ventricle, contracting and squeezing at the same time to push blood out into the pulmonary circulation or out into the systemic circulation. So atrial contraction, right or left together, and ventricular contraction, right and left ventricle, they are happening at the same time. Atria contract, ventricular contract, atria contract, ventricular contract, atria contract, ventricular contract. So that is what is happening every minute, every second in our body. And we said, you know, 4 valves, tricuspid, pulmonary, mitral, and aortic. So if you look at from the top side, you can see the valves here. So this is the tricuspid valve. We said tricuspid, 3 leaflet valve, 3 caps. So this is 1 cap, another cap, and another cap. So 3 cap tricuspid. So what about the aortic and pulmonary? They also have 3 leaflets, and therefore aortic valve, pulmonary valve are also structurally, they are tricuspid, because they have 3. So that's what I say, you know, every part of the body, if you don't know something, just say 3. So brain is covered with meninges. How many layers do meninges have? 3 layers. How many layers the heart have? 3 layers, endocardium, myocardium, epicardium. And how many leaflets do our heart valves have? 3, tricuspid. Tricuspid valve, aortic valve has also 3 leaflets, and pulmonary valve has also 3 leaflets. It is a little naughty with mitral valve. Mitral valve has only 2 leaflets, and therefore it is the exception. Mitral, mitre, M-I-T-E-R. Mitral comes from mitre. It is a bicuspid valve, only 2 bicuspid valve. Mitre stands for the bishop's head, 1 leaflet here and another leaflet here. That is the mitre's head. So this mitre, the name mitre comes from the mitre, the head of a bishop. So 2 leaflet. That's why mitral valve is a bicuspid valve. The rest of the valves are structurally tricuspid valve, but of course their name changed, and the tricuspid valve, only the tricuspid valve is called tricuspid, aortic, and pulmonary, because they are going into the aorta and pulmonary into the lungs. So now this diagram became a little bit more clear for you guys. Like tricuspid valve is here, pulmonary valve is here, mitral valve is here, and the aortic valve is here. And the blood flow back can go into the systemic circulation. Right. And in between 2 ventricles, we can see 2 ventricles are separated by the interventricular septums. So look at that, this interventricular septum. So 2 ventricles are separated by interventricular septum. In between ventricle, interventricular septum. The same thing, 2 atriums are separated by interatrial septum. So that is a partition between 2 atria and 2 ventricles. So this is not a big thing to remember. So interventricular septum. So look at the interventricular septum. Its wall is also pretty thick because it is part of the left ventricle. So look at the valves here. So this is the tricuspid. We are going to look at the tricuspid and mitral valve. So that is like, you know, it's just ventricles contract, forcing the blood against the AV valve. So tricuspid and mitral. But AV valve closed, and papillary muscles through the chordae tendineae, trabeculae carneae. Trabeculae carneae is the little ridge inside. It's similar to the papillary muscle. With the chordae tendineae, look at the chordae tendineae, tendinous cord. Make sure these valves do not go back into the atria. That is the job of these Yeah, so it's too boring now. Let's move on. That is this diagram is showing the inner surface of the atrium. You know that already. Most of the inner surface of the atrium is nice and smooth. Only a small portion, like in the right atrium, this pectinate muscles, like little longitudinal muscles, little longitudinal muscles here. That is the pectinate muscle. And in the left atria as well, they have a small piece of pectinate muscle, but not as much as the right atrium. And look at the smooth surface, and you can see the crescent shape. I will show you again here. This crescent shape, the posterior to the crescent shape, we got the superior vena cava and inferior vena cava coming. That is the crescent shape it is showing. This crescent is called crista terminalis. So this is a good to know information. So crista terminalis is a crescent shaped ridge which is splitting the anterior portion of the right atrium and the posterior portion of the left right atrium. So posterior portion of the crista terminalis is nice and smooth. Anterior portion of the crista terminalis is, we have the pectinate muscle. And in the posterior to the crista terminalis, the superior vena cava, inferior vena cava will go in. The coronary sinus, which is the vein, big vein coming back from the heart, will come back into the atrium anterior to the crista terminalis. That is all about the right atrium. It's too much. So right atrium, so let's try to consolidate our knowledge. Right atrium forms the right border of the heart. Smooth wall posteriorly, pectinate muscle anteriorly. This anterior and posterior, the division is the crista terminalis. It is a little ridge, crescent-shaped ridge. And fossa ovalis is posterior to the crista terminalis. So fossa ovalis is a place where the two atria walls stack together. So now I hope this slide is not very raw for you, and I believe you will be familiar with this. And this again showing the inner aspect of the right ventricle, and the pectinate muscle is showing here, pectinate muscle here. And now let's look at the right ventricle. It forms the most of the anterior surface of the heart. That is not new information. You know the papillary muscle, you know the chordae tendineae, and you know the trabeculae carneae. So inside of the right ventricle, that is what you're going to see, and it makes the anterior portion. Let's say if I ask you a question, tell me something about the right ventricle. So I want you to say like 2-3 line sentences. So if anyone, like, because you are studying anatomy, might be one of your friends who is not studying anatomy, or what might be one of your relatives will ask me, hey, tell me about the right ventricle. I don't know that. Hey, tell me about the right atrium. So you have to come up with a few little sentences. So these are the few little sentences which you can use just to explain your little sister or maybe your friend. Okay, so that's what we were talking about. Papillary muscles, where are the papillary muscles? You can see the papillary muscles here. Chordae tendineae, these are the chordae, tendinous cord, chordae tendineae. Trabeculae carneae. Trabeculae carneae is a trabecular mesh wall-like structures. So what is the big difference between trabeculae carneae and papillary muscle? No big difference at all. They do the same job. This is the muscle. These are a little bit more trabecular-like structure, and that's why the name change. Okay, so now you can see that, and now you can see the trabeculae carneae. This is a diagram I got it from University of Minnesota. Trabeculae carneae, hey, trabecular-like structure, like you remember the bone structure, trabecular, and you can see the chordae tendineae. tendinous cord, and papillary muscle, big, thick muscles, papillary muscle. They are everything inside the both right ventricle and the left ventricle. So now the blood is coming back both into the right ventricle and both into the right atrium and the right ventricle and the left atrium. And sorry guys, it's a, what do you call that, spam call. So the blood, the whole body coming back into the right atrium, the oxygenated blood from the lungs come back into the left atrium. They happen at the same time. The blood will be coming back into the atrium, right atrium, left atrium at the same time. And now, as the blood returning to the heart, fills atria, pressing against the AV valve, the increased pressure force the AV valve to open. Yeah, so now once that is filled enough, there will be increased force and pressure. This pressure will open the tricuspid and mitral valve, and the blood can come into the ventricles. But of course, at the end, there is less blood in the atrium, more blood in the ventricle. Finally, the ventricle, we have to give a final squeeze to make sure ventricles are fully filled. All its contents, atrial contents plus, are fully pushed into the ventricle. So that's the leaflets of the heart, and these are the chordae tendineae. So left atrium, most of the posterior surface of the heart, you know that, smooth inside. Pectinate muscle, you have a small amount of pectinate muscle, and not much to talk about left atrium because it is pretty benign. It will accept blood, oxygenated blood back from the lung, and that is all about it, left atrium. Left ventricle, pretty similar to the right ventricle. It forms the apex and most of the inferior surface of the heart. We know that papillary muscle, chordae tendineae, trabecular cardiac, the same right atrium and right ventricle. So like if I ask you, tell me something about the left ventricle, that is what I want you to say. Because this will be going to be part of the homework. So my question will be, write 3 sentences about right ventricle. So I want you to write like that. That's all. Okay, so this is right ventricle filled with blood and just about to contract, and the tricuspid valve is going to close. Cardiac skeleton, you know that already. I'm not going to repeat that. And heart sound, now you know where to listen somebody's heart sound. So ATPM, and from our surface anatomy knowledge, third costal cartilage, 6th costal cartilage, 2nd intercostal space, 5th intercostal space. But of course, we are listening the heart sound. So we will not listen on the bone. We will slightly move upwards. And therefore, on the right, 2nd intercostal space, just on the right of the sternum, 5th intercostal space, just on the right of the sternum, 2nd intercostal space, just lateral to the sternum, and 5th intercostal space, but it is in the mid-clavicular line. You will hear the heart sound of the aortic, tricuspid, pulmonary, and mitral. And as we say, you know, both ventricles are contracting, and then both atrias will contract. Atrial contraction, ventricular contraction. Atrial contraction, ventricular contraction. Atrial contraction, ventricular contraction. It's non-stop, going on and on. Atrial contraction, ventricular contraction. So when the atria contract, it is the less time of the aortic and less part of the, when the atria contract, it is the less movement of the tricuspid and mitral valve to open. So once the ventricles start to contract, and just before the blood go out into the aorta and pulmonary, it has to close the connection with the atria. On the right ventricle, once the right ventricle start to contract, it will close the tricuspid valve. On the left ventricle, once the left ventricle start to contract, it will has to close the mitral valve. So once the ventricle starting to contract, aortic and mitral valve will close. That closure of the valve, we can hear as a heart sound, as a lip. So lip is the mitral valve closure. And then the ventricles keep contracting. All the valves are closed already. The blood is going through the aortic and pulmonary. The blood is flowing out of the ventricle. Aortic and pulmonary valves are opening. And now ventricle is going to relax. Once the ventricle is starting to relax, aortic and pulmonary valve gradually close again. So this closure of the aortic and pulmonary valve at the end of the ventricular contraction, which is what we call ventricular systole. At the end of the ventricular systole, the aortic and pulmonary valve close, and this closure make another noise. That is what we call second heart sound. So second heart sound is made of aortic and pulmonary valve closure, and it is hard as dub, lup, dub, lup, dub. So whatever books you read, they are going to write like that, lep and dub. Lep is the first heart sound, which is coming from the mitral and tricuspid valve closure, and dub is the heart sound coming from the aortic and pulmonary valves. So whenever you have a chance to use the stethoscope and listen to somebody's heart, this is what you are going to hear. Lep, dub, lep, dub. And depends on where you listen, where you put your stethoscope. If you put here, just on the right side of the sternum, in the second intercostal space, if you hear a sound, that is the aortic valve closure sound. So now we are coming close to the end of the lecture. So valve disorder. So any valve, like if you think about the valve, just think like a door or window in your home. So that window, that valve can be incompetent. So it is not closing fully, which is supposed to close fully. So there will be leakage. When the ventricles contract, there will be leakage of flow because it cannot close properly. Or that window can be small, like stenosis. Or because of the damage to the chordae tendineae, which are supposed to pull the valve, not to prolapse into the atrium, then if these chordae tendineae are damaged, they can prolapse into the valve can prolapse into the opposite part of the ventricle as well. So these are the disorders we can get with the pulmonary, mitral, tricuspid, and aortic valve. It could be incompetent, it could be stenotic, or it could be the valves can prolapse into the opposite direction. And murmur. What is a murmur? Murmur is an audible turbulent flow. Audible, any turbulent flow which you can listen with your ear, it is called murmur. So let's say if you put your hand on a turbulent blood flow, your hand will feel it. So that is what we call thrill, T-H-R-I-L, thrill. So if there is any turbulent flow here, and if I put my hand on the turbulent flow, my hand will feel something underneath this turbulent flow. It is called the thrill. And if you put your stethoscope on the turbulent flow, this turbulent flow is called murmur. So if the valve is small and stenotic, and if normal amount of blood has to go through the valve, it will create turbulent flow. That turbulent flow we will hear as murmur. So just try to separate between the first heart sound, second heart sound, and the additional sound. which could be mama. So yeah, this is what we were talking about. Let's say if the left ventricles and right ventricle contract, the blood will have to go through the pulmonary valve and aortic valve into the pulmonary tract and aorta. But let's say if this valve cannot close properly, then the blood from here will be coming back into the ventricles. That is what we call incompetence. It's too much. So now let's go to the easier bit. Let's go to the easier bit. So the heart has got its autonomicity. I just wonder, whether when you are doing biology class, just wonder whether you might have to take out the heart of a frog and put it into the saline. And if you keep looking at that, the heart is keep beating. A human being is very cruel, isn't it? We take out somebody's heart and we study, of course, for the good, good purpose and good intention. And I hope this thing will not happen to us. But when we do the biology class, we just open the heart, open the thorax of the frog. We take the heart out and we put that heart into the normal saline, and that heart keeps beating, keep beating, because it has got autogenicity, like it just keeps spontaneous generation of the electrical impulse. That is one of the properties of the cardiac muscle, which you will have to study in physiology. So yes, the heart itself has its own autonomicity, but the heart is controlled by the sympathetic and parasympathetic nervous system. So sympathetic nervous system here, sympathetic nervous system, which you will have to learn later during the semester. Sympathetic nervous system is for fight and flight situation. So your heart rate will go up, your pupil will go up, you are ready to fight back or you are ready to run. So sympathetic will increase your heart rate. And the same thing, parasympathetic, which is situated in the cardio-inhibitory center in the medulla oblongata. So medulla oblongata is the brain, part of the brainstem. So from the medulla oblongata, we have a cardio-inhibitory center. From this center, a nerve, which is what we call vagus nerve, will come out and supply the heart as well. The same thing. So the vagus nerve will slow down the heart rate. The sympathetic will increase the heart rate. So sympathetic and parasympathetic need to be balanced so that our heart rate is controlled around 70 to 80. On top of that, the heart itself has got its own rhythmicity, its own autonomicity, which so contraction inside the heart. So these electrical impulses, so as I say, different parts of the heart has their own autonomicity and autonomic contraction. So right atrium has got its own autonomic contraction. Left atrium has got its own autonomic contraction. Right ventricle has its own, and left ventricle has its own. So how can we control everything together? The good thing about the heart is it obeys the all or none law, the heart muscles. So when there is contraction, that is it. It will follow the contraction. So you cannot say like, different people talking different. No, it's one rule. So it's like a military. Hey, this is an order and follow the order. So the same thing, like although every part of the heart has its own autonomicity and rhythmicity, if one heart controls, the rest will fade away. So this generation is coming from the sinoatrial nodes. So sinoatrial nodes is the big daddy of the heart. So it generate electrical impulse. That impulse will spread to the every part of the body, and that control the other parts of the heart to follow its direction. So that is why sinoatrial node is really important. As a node, in short, sinoatrial node, it is situated in the right atrium, just closely around the superior vena cava entrance. And it will go to the along the internodal pathway to another node, which we call AV node. AV node is still in the atrium, but it is close to the lower part of the atrium in the interatrial septum. And from there, AV bundle, right bundle, and Purkinje fiber. So let's have a look. This diagram might be easier to follow. So sinoatrial node as a node, which is close to the opening of the superior vena cava. This is the big daddy because the rate its SA node generate is the fastest, and therefore it commands every other part of the heart to follow the SA node's order. So at the SA node, we generate impulse, and all the different part of the heart we have to follow the lead of the SA node. So this SA node will generate impulse, and through the along the track, it will go to the atrial AV nodes, atrioventricular node. AV node is still in the atrium, but in the lower part of the atrium. And from the atrium, it will go into the atrioventricular bundle. Look at that, number 3, atrioventricular bundle, from the atrium into the ventricle. And just above portion of the interventricular septum, it's split into right bundle and the left bundle. And this right bundle and left bundle gradually fragment into the Purkinje fibers. Purkinje fibers, where is the bundle? So subendothelial network here, yeah? Purkinje fibers. So that is the that is the pathway of the electrical impulse from the atrium into the ventricle into the rest of the heart. That's why the SA node contract, so SA node stimulate, atria will contract, and the impulse will keep coming down. The ventricle, so ventricles will contract from the bottom, and SA node will contract from the top. So that is the way we create the blood flow as well. So SA node, AV bundle, bundle branch, subendocardial conducting network. So I would say this diagram is a mesh node. You need to know the SA node, you need to know the AV node. From SA node to the AV node, so internodal pathway, in between two nodes, internodal pathway, SA node to AV node. And then the AV bundle from the atrium to the ventricle, AV bundle, and right bundle and left bundle, and then endocardia, and just underneath the endocardium, subendocardial conduction network. Subendocardial conduction network is called Purkinje fibers. So yeah, so don't get upset. It's nearly end of the lecture. So the heart itself, its own rhythmicity, SA node, AV node. SA node control every other part of the heart, but SA node will be influenced by the sympathetic and parasympathetic nervous system. So that if when we get excited, sympathetic activity goes up and our heartbeat can go up. When we are too bored and lazy, and if we want to relax, parasympathetic will come in. Parasympathetic will slow our heart. So sympathetic and parasympathetic, it need to balance so that we got the optimal heart rate, might be about 70 to 80. So finally getting close to the end of the lecture, this is for your knowledge. So congenital heart disease, which is really common, which is really 1 in 150 people can get can get the congenital heart disease. This is a very rough, you don't need to know this, because if I do not tell you, you won't understand how can we get the congenital heart disease. So that's why this is the embryology of the heart. So at the day 20 of conception, so very, very young, within 20 days after the conception, our heart tube, which is called endothelial tubes, they start to get lengthened, become longer, and then they gradually get fused. And this fused tubular structure will gradually loop around, like a loop around, and then fold it, and finally it becomes heart. So that is really amazing structure, two tubes fused together and twist around, and finally some part of the body get fused, some part of the body doesn't get fused, and finally we get our heart, which is such a complicated structure. And these are the mechanical heart valve, biological heart valve. So this is such a complicated process. What can it go wrong? Of course, it can go wrong in many different ways, because the two tubes attached together, getting longer, and twist and spiral around, and to get a heart. That is such a complicated process. So sometimes there is a connection between the left portion of the heart and right portion of the heart. That is a disaster. That is a disaster, because if the left ventricle and the right ventricle are connecting to each other, so the ventricle between the partition between the ventricle, which is interventricular septum, if there is a hole in the interventricular septum, that is what we call defect in the interventricular septum, interventricular septic defect. The blood from the left side can go into the right. The deoxygenated blood from the right side can go into the left. And this deoxygenated blood will go into the aorta, into the systemic circulation. So we will get deoxygenated blood in our body, which is a disaster. And at the same time, the right ventricle blood will have to go into the pulmonary. Left ventricle blood will go into the aorta. Let's say if there is something wrong with the twisting, and if the right ventricle blood is going into the aorta and left ventricle blood is going into the pulmonary tract, how can we get oxygen in our brain? How can we get oxygen in every part of the body? So this condition is really serious. The baby is born with blue baby born. And look at that, look at the heart. And this is what we call transposition of the great vessels. Our aorta and pulmonary valve are originating from the different ventricles. That is a disaster. That little baby needs immediate operation. It is a nightmare. So heart valves, don't forget that. And what is happening here? So look at that. The right ventricle, left ventricle through the aortic valve into the aorta. Some portion of the aorta is narrow. That is a condition we call coarctation of aorta. If you think about that, this left ventricle, originally it has a big pressure to pump out blood already, because it has to spread the blood into the whole body, top to toe. And now on top of that, there is a narrowing, so such a big pressure for the left ventricle to pump out blood. That is what we call coarctation of aorta. And look at this condition. This is what we call tetralogy of Fallot. Tetralogy, 4 problems here. Tetralogy, so the pulmonary valve is narrowed. the exit from the right ventricle into the pulmonary valve, it's finding difficult. And therefore, the right ventricle blood will go into the left ventricle, and there is a defect in the right ventricle. And this deoxygenated blood will get distributed into the circulation. So that is again like a big problem, tetralogy of Fallot. It is not as bad as this transposition of great vessel. It's not as bad, but it is also very serious problem. So tetralogy of ventricular septal defect, pulmonary stenosis, narrowing, overriding. So there is a lot of blood going into the aorta. This a lot of blood does not mean good blood, because it is mixed with venous blood. So the body is getting mixed venous and arterial blood. Such a disaster problem. So things can go wrong. Things can go wrong because of the two tubes fusing together, getting longer and twisting together. Many different things can go wrong. So if you have a normal heart, it is a blessing. So now we have some information about ECG. Of course, we are not a ECG course, but I want you to try to relate the anatomy of the heart and the way ECG is trying to look at the heart. And this is some basic of ECG. When the heart contract, when the atria, as I say, right atria and left atrium contract together, the blood from atrium will go into the ventricle. The right ventricle and left ventricle will contract together. The blood will go into the pulmonary and aorta. So when the right atriums contract, this electricity impulse is catched by the ECG machine as P wave. When the ventricles contract, because ventricles are much bigger, so the electrical impulse generated by the ventricles is much bigger than the atria. This is something we see as QRS. And this is the T wave. T wave is the depolarization, the relaxation of the ventricle that creates T wave. So don't forget P, QRS, T. So that is the basic of ECG. And now we come to the irregular heartbeats and irregular rhythms. As we know, the big daddy is the sinoatrial node, which is situated in the atrium. It overrules every part of the heart. Although different parts of the heart have different activity and different autonomicity, but this SA node controls everything. When there is a problem with the SA node, or when there is a internodal pathway problem, or when there is a AV node problem, when there is a atrioventricular pathway problem, when there is a problem with the right ventrals and left ventral, every part of the cardiac conduction system, if they get damaged, we are going to get irregular heartbeat. So if you look at that, if you look at this ECG, this is the QRS. We saw that this is the QRS. We know that QRS. Can we see P wave here? So no effective P wave. Yeah, you can see only the sawtooth here. You cannot see a proper P wave like that. You can only see a sawtooth zigzag P wave. So there is no effective P wave, which means there is no effective atrial contraction. And look at the heart rate, So the space, QRS space between this and that is small, and here and there is long. Medium, short, long, medium, long. So the heart is contracting in a irregular pattern. That is, this ECG we can see in atrial fibrillation. Atria are contraction in an awkward position. Therefore, there is no effective atrial contraction. And ventricles are responding in a different way on its own. So there is not much, the ventricle contract on its own. Yes, ventricle contract on its own, but there is no such a relationship between the atrial contraction and ventricle contraction. This ECG is a ECG for the atrial fibrillation. So look at this ECG. Look at that P wave, this QRS, and this segment is high. Look at that, it is marked with the yellow, the QRS. So this is the QRS, this segment we are looking about, QRS, ST segment. So the segment between the S and the T, this segment we are looking about. This ST segment is high here. This ST segment is high here. So ST elevation, that is the ECG feature of myocardial infarction, heart attack. So depending on which portion of the heart, look at that AVL here. Look at that V5. Look at here, V4. So it is damaging the V6. So which means anterior leads. V4, 5, 6 to me, the anterior heart on the left side is getting ischemia. So that might be left ventricle myocardial infarction. So that is the way we interpret ECG. All right, so I have a question here. So can that happen every now and then, irregular heartbeats? Well, ideally not. We should not have an irregular heartbeat. We should have just this, repeated this, P wave, atrial contraction, QRS, ventricular contraction, T wave, ventricular relaxation, and U wave. So P wave, QRS, ST, T, that is the repetition. That is what we need. So, that's why if someone is having like, hey, that's why you do not aware of your own heartbeat, because atrial contract, ventricle contract, atrial contract, ventricle contract. That is just keep going, keep going. Might be atrial contract quick, ventricle quick, or might be slow, contract, 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 contract. So this need to be repeated and changed. So once there is, so that's why you are not aware of your own heartbeat. So if you start becoming